Duk-Woo Park, Mike Gibson coming to you from ESC 2023, and we are talking about the OCTIVUS trial, OCT versus IVUS. Talk to us about the study.
Yes, OCTIVUS trial in the pragmatic, the multicenter random trial, and looking at the background, the imaging guided PCI, the IVUS or OCT shows the better outcome compared to angiography guided PCI on the basis of many random trial. But each imaging modality or OCT or IVUS has different imaging technology and regional application and the limitation or advantage. So our OCTIVUS trial is comparative effectiveness RCT, is comparing OCT or IVUS for PCI guidance and the broad range of patient undergoing PCI.
And talk to us a little bit about how many patients, what was the protocol?
So, and our trial is a pragmatic random trial. Finally, we include initially target 2,000 patients, and finally we include the 2,008 patient. OCT group was randomized 1,005, and IVUS group randomized 1,003.
And how does, when you say randomized, before the PCI was done, that strategy was selected, not after you'd seen the anatomy or you'd seen the anatomy first? What was the timing of the randomization?
Yes, I think that is a very good point. Usually, and the random was done. The patient is agree to participate our trial and fully understand the purpose of our trial. We did randomization at the time of just before PCI, and so we use the imaging guided PCI. So, and on the basis of randomization sequence and the OCT guided use OCT, IVUS guided PCI group use IVUS.
And what did you find?
So, and you know, you means major finding for our OCTIVUS trial. So, you know, endpoint is our trial has a primary endpoint is a target vessel failure. This is the composite of death from cardiac death or target vessel MI or target vessel repeat revascularization. That is the primary endpoint. Also, we evaluated the diverse important secondary endpoint, target lesion failure, stent thrombosis, rehospitalization, contrast-induced renal injury, or processing complication.
And how did the strategies compare?
So, and you know, usually and the strategy is OCT guided PCI. We fully use the OCT and the before or during and the final procedure. That is the same for IVUS guided PCI, and during the PCI we can use the before PCI, during PCI, even after final PCI. Our protocol mandatorily recommendation for final optimization should be confirmed, assigned the imaging modality, OCT or IVUS.
Was there any crossover, Duk-Woo?
Yes, there is just a little crossover, and the overall and less than just 1%, and the instance of rate of crossover much higher in the OCT guided group, and just a little bit, and so our trial performed as treated for protocol analysis.
So for the primary endpoint, were there any differences?
Yeah, so primary endpoint is 1 year target vessel failure, and there is absolutely our trial primary purpose would like to confirm the OCT guided PCI would be non-inferior to IVUS guided PCI, and at 1 year primary endpoint, IVUS guided PCI group target vessel failure 3.1%, OCT guided group is a 2.5%. So, and the p-value for non-inferiority less than 0.001. So our primary purpose and the non-inferiority was met.
And Duk-Woo, what was the non-inferiority margin, the pre-specified non-inferiority margin?
Yeah, so I think that is the major limitation. So at the time of the randomization, our trial was targeting for the broad range of the population. So at the time of the designing, some random trial was existed, but however, that trial just confined the one specific region, CTO region or diffusion long region. There is it's a broad range pragmatic trial. So our conventional group overall event rate assumption is very difficult. So the reason why we used our prior experience, real world registry data. So IVUS group, we defined assess 8.0% 1 year, and the non-inferiority margin were used 3.1 non-inferior margin. There was would represent 35% expected percentage of patient with the event. I think that is the major limitation. So at the time of the analysis, we recognize our initial, the expected event rate is too much ambitious. That is our major finding is the lower than expected primary endpoint.
So you had less than half the anticipated events, or maybe almost.
Absolutely.
So you had less power than you thought to assess non-inferiority. Were there any subgroups that stood out that where one strategy had a better outcome than the other?
Yeah, I think that the most of interventional cardiologists would be very interested in which population we can achieve this better outcome with the specific imaging group. And we did the several important subgroup analysis, including clinical factor, the like diabetics, and the sex and the gender. Also, we did pre-specified multi-group analysis, left domain, bifurcation, diffuse and calcified region. We didn't find any statistical interaction. For overall finding was comparable and consistent in pre-specified major subgroup.
And for your secondary endpoints, things like stent thrombosis, other individual secondary endpoints, was there any difference between the strategies?
Yes, overall the key secondary endpoint, repeat revascularization, stent thrombosis was comparable. Also, one of the important finding, the use of the contrast dye much higher as expected in OCT group, and we are initially concerned about the contrast-induced nephropathy would be higher in the OCT group. However, as a result, and the overall instance of the contrast in the induced nephropathy was comparable between the OCT and IVUS group, and we didn't find any statistical significant difference.
So, Duk-Woo, what's the take-home message for practicing interventional cardiologists?
Yes, so I think that our trial, although has some limitations, so we believe and our trial was reconfirmed the existing evidence. And if you're going to use the imaging-guided PCI, we achieved a better outcome. The key message was OCT was non-inferior to the prior conventional IVUS in the major clinical outcome. So I think if you're going to use the imaging-guided PCI, our trial is fully support, and you can choose the OCT or you can choose the IVUS, and both imaging modality can be equally effective to improve your outcome in your daily PCI practice. That is my final message.
Great. Duk-Woo, thank you for sharing with us. Thanks for joining us. And thanks to all of you for joining us here from ESC 2023.
Thank you.